So we're going to talk a little bit about growth hormone deficiency diagnosis in children and management. It's really an overview so that we can start discussions in it. So disclosures. And I suppose the first thing is when we'd like to consider investigations for GHD, and these really come from the time of the GRS meeting, which was back in 1999, and seem to have been followed through ever since that time. They do seem quite marked in some of the degrees of growth hormone deficiency before they recommend investigations. So for height itself, being less than 3 standard deviations below the mean is obviously quite a long way down from what you'd expect. Or better though is if we've got a midparental height and less than 1.5 SDs below midparental height. But rather than height, height velocity seems a much better marker, but obviously we need prospective data there to follow people and look at how fast they're growing really to get a better idea. But it seems to be a more accurate way of assessing growth auxiologically. So in that, they recommend less than 2 standard deviations below the mean over 1 year, or over 2 years less than 1.5 standard deviations. So it is quite a bit of follow-up to really hit those height velocity targets. Other things that help us in deciding who to investigate, and obviously coming to a diagnosis earlier, would be patients who have known hypothalamic pituitary lesions, where we know they're at risk of hypopituitarism. Multiple pituitary hormone deficits. We know if you're deficient in a number of hormones, you're highly likely to be growth hormone deficient. Cranial irradiation of patients, a lot of the cohort that I would follow, looking at regular tests to see if these patients develop growth hormone deficiency. And I feel in that cohort, you can pick up these people when they become growth hormone deficiency by prospective testing and before they've lost that height, making things easier to treat. And then there'll be those who have neonatal symptoms when they present really early with growth hormone deficiency, such as hypoglycemia or the mid-facial formations, the malformation they get. And then obviously the people that Mello has already mentioned in the craniofacial midline problems. So diagnosis in children, growth hormone deficiency is fairly rare still. It's about 1 in 4,000 children. So we're not talking something that's common. And other causes of growth hormone deficiency are probably a lot more common than growth hormone deficiency. So we need to consider those first. And simple things like hypothyroidism, whether they have a skeletal disease. Obviously the Turners may be a little bit more obvious. And those who have chronic illness obviously all have a reduction in growth. So the cancer survivors that I see again, they significantly reduce height velocity and height whilst they're unwell. And as soon as we put them into remission, you see that catch-up growth. They're not in a lot of them are not growth hormone deficiency, and they pick up without us intervening. Diagnosis, as we've already mentioned, has several criteria. We need the auxiological criteria, which we have in children, which is really important, that we just mentioned. Clearly, we don't have that in adults and at transition, but in children, it really is a great help in diagnosing growth hormone deficiency. We then need the biological testing, which is the bit that's a little bit more tricky. We need a growth hormone provocative test, and there's been plenty of those that have been used in the past and still used. And then IGF-1 and BP3, which we mentioned a little bit already about that being an additional helpful test at times, but not others. Radiological evaluations, again for bone age, to look at skeletal maturity will help us. If there's delay, that will help us. And obviously, as we mentioned with the obese patients, if it's ahead of time, ahead of chronological age, that may be against the diagnosis of growth hormone deficiency. If we're thinking there's a cranial lesion, then obviously MRI scans to look at the hypothalamic pituitary area, and that would support our diagnosis of growth hormone deficiency as well. And then genetic analysis, which is something that's becoming more widespread in a lot of conditions within endocrinology now. And the patients we should be doing in that. And it tends to be those who've got a family history or those with more severe disease, either because it's of earlier onset or the provocative tests are particularly low or the IGF-1s are particularly low to guide us that they may have a genetic cause. How do we confirm growth hormone deficiency? We've touched on that a little bit. So the provocative tests are the mainstay. And there's some I've mentioned there, like the insulin, the arginine, the glucagon, clonidine test, but there's been plenty of different ones in the past, like exercise tests, Bovril tests, many of which have very little in the way of sensitivity and specificity for the diagnosis, and fortunately we no longer use. If we have a patient who has isolated growth hormone deficiency, they ideally should have 2 tests, though in people, as we've mentioned, if you've got multiple pituitary hormone deficiencies, because the risk of growth hormone deficiency is so high, then 1 test would be adequate. And there's several things like that. Similar if you've got a anatomical lesion of the HP axis or a history of radiation, where we think 1 test would therefore be adequate. Diagnostic cutoffs. I think most of us now have settled on a diagnostic cutoff of somewhere around 7, really, for where we would consider children to be growth hormone deficient. And that seems to tie in with the auxological data that we have, or certainly is the best cutoff for the auxological data. But that's still a matter of debate. And obviously, there may be that in transition where we're considering, in puberty, where we're considering a slightly higher cutoff value, or where all the other data seems to suggest patients are growth hormone deficient. And if they've got a level between 7 and 10, then maybe worth trying growth hormone replacement. IGF-1 and BP3, if they're below the normative range at less than -2 standard deviations, again, may well be a help in our diagnosis. Our goals of management really are in children, predominantly to optimize our growth of our children to that which we think is similar to mid-parental height, and try to optimize that. To date, we're not generally achieving that, and there may be a number of factors to be discussed later, like adherence, which are factors in that, but also the fact that by the time we have diagnosed growth hormone deficiency, we have less time to treat the patient and bring their growth up before puberty fuses the epiphysis.